Welcome to this Step 2 clinical knowledge review on pelvic pain and endometriosis test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for pelvic pain and endometriosis, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the reproductive and gynecology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn to recognize high-yield question stems for pelvic pain and endometriosis on your board exam. Second, we will apply specific test-taking strategies for acute pelvic pain, chronic pelvic pain, and ovarian torsion questions. Third, we will master the next best step question format for diagnosing and managing endometriosis and pelvic emergencies. Before watching, make sure you have reviewed the relevant chapters in first aid and completed practice questions in your question bank. This video is about strategy, not content review. Our first strategy is the acute versus chronic pelvic pain split. When you see a question about pelvic pain, immediately ask yourself, is this acute or chronic? For acute pelvic pain, the key buzzwords are sudden onset, peritoneal signs, and hemodynamic instability. Ectopic pregnancy is the most dangerous cause and must always be ruled out first with a pregnancy test. Ovarian torsion presents with sudden unilateral pain, nausea, and an adnexal mass. This distinction drives your next best step. For chronic pelvic pain, look for pain lasting more than 6 months and whether the pattern is cyclical or non-cyclical. Cyclical pain that worsens with menses strongly suggests endometriosis. Non-cyclical pain with vaginal discharge or cervical motion tenderness points to chronic pelvic inflammatory disease. The boards love testing this framework, so make it your first mental framework when approaching these questions. Strategy 2 is the endometriosis recognition framework. For classic endometriosis clues, look for cyclical pelvic pain that worsens before and during menses in a reproductive age woman. The dysmenorrhea is progressively worsening, which is a key differentiator from primary dysmenorrhea. Deep dyspareunia, dyschezia around menses, and infertility round out the classic cluster. When you see this combination of findings, always think endometriosis. For surgical and advanced clues, look for a fixed retroverted uterus and uterosacral nodularity on pelvic exam. Endometriomas appear as chocolate cysts on imaging, showing homogeneous low-level echoes on ultrasound. Remember that definitive diagnosis requires laparoscopy with biopsy showing endometrial glands and stroma outside the uterus. These are classic board findings that you need to recognize instantly. Let us review the 3 most important stem patterns. For ovarian torsion, the stem will describe a young woman with sudden-onset severe unilateral pelvic pain with nausea and vomiting. There may be an adnexal mass, and Doppler ultrasound will show decreased or absent blood flow. Remember, torsion is a surgical emergency. For endometriosis, look for a reproductive age woman with progressive dysmenorrhea, chronic pelvic pain, dyspareunia, and infertility. The exam may describe uterosacral nodularity or a fixed retroverted uterus. For ectopic pregnancy, the stem will give you a woman of reproductive age with pelvic pain, vaginal bleeding, and a positive pregnancy test. Transvaginal ultrasound shows no intrauterine pregnancy. Always check a beta-human chorionic gonadotropin level in these patients. Let us work through our first practice question. A 23-year-old woman presents with sudden-onset right-sided pelvic pain that began 6 hours ago. She describes the pain as sharp and constant and has vomited twice. On exam, there is right adnexal tenderness with a palpable mass. Doppler ultrasound shows a right ovarian mass with absent arterial flow. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Young woman, sudden onset unilateral pain, nausea, vomiting, adnexal mass, and absent blood flow on Doppler. That absent arterial flow is the classic identifier for ovarian torsion. Step 2. Apply the rule. The board rule you must memorize is that ovarian torsion is a surgical emergency. The next best step is always surgical exploration. Any delay risks permanent loss of the ovary due to ischemia and necrosis. Step 3. Eliminate wrong answers. Observation delays treatment of a surgical emergency and risks losing the ovary. Outpatient follow-up is completely inappropriate when there is absent blood flow. Intravenous antibiotics treat pelvic inflammatory disease, not torsion. The absent flow and adnexal mass make this surgical. The correct answer is C, surgical exploration with ovarian detorsion. Here is our second practice question. A 30-year-old woman presents with a 3-year history of progressively worsening dysmenorrhea and deep dyspareunia. She and her partner have been unable to conceive for 18 months. On pelvic exam, there is a fixed retroverted uterus and tender nodularity along the uterosacral ligaments. Transvaginal ultrasound shows a 4 cm left ovarian cyst with homogeneous low-level echoes. What is the most likely diagnosis? Think through your answer before we review the walkthrough. Let us walk through this one carefully. Read the question carefully. The question describes a classic endometriosis presentation. Progressive dysmenorrhea, meaning it gets worse over time, deep dyspareunia, infertility, a fixed retroverted uterus, and uterosacral nodularity on exam. The ovarian cyst with homogeneous low-level echoes is an endometrioma, also called a chocolate cyst. Now, why is endometriosis the answer? A functional ovarian cyst would not explain the progressive symptoms, the fixed uterus, or the uterosacral nodularity. Ovarian malignancy typically shows complex features on ultrasound with solid and cystic components, not homogeneous echoes. Chronic pelvic inflammatory disease would more likely present with vaginal discharge, cervical motion tenderness, and a history of prior infections. The correct answer is C, endometriosis. Now let us review endometriosis management for the boards. For medical management, first-line therapy is combined oral contraceptive pills or progestins to suppress estrogen-driven endometrial growth. Second line includes gonadotropin-releasing hormone agonists such as loprolide, which create a hypoestrogenic state. When using these agents, add-back therapy with low-dose estrogen and progesterone is important to reduce side effects like bone loss and hot flashes. For surgical management, laparoscopy is both diagnostic and therapeutic. Excision or ablation of endometrial implants can improve both pain and fertility. Endometriomas larger than 4 centimeters may require cystectomy. Hysterectomy with bilateral salpingo-oophorectomy is definitive treatment for women who have completed childbearing. The boards love asking about the next step when medical therapy fails, and the answer is usually laparoscopy. Let us try our third practice question. A 26-year-old woman presents to the emergency department with sudden onset, left lower quadrant pain and vaginal spotting. Her last menstrual period was 7 weeks ago. A urine pregnancy test is positive. Vital signs show a heart rate of 100 and blood pressure of 90/60. Transvaginal ultrasound shows no intrauterine pregnancy and free fluid in the posterior cul-de-sac. What is the most appropriate next step in management? Think carefully about the clinical scenario before we walk through the answer. Let us break down this answer. Spot the classic pattern. We have a positive pregnancy test, sudden pelvic pain, vaginal spotting, tachycardia, hypertension, no intrauterine pregnancy on ultrasound, and free fluid in the cul-de-sac. This is a ruptured ectopic pregnancy until proven otherwise. The hemodynamic instability with tachycardia and hypertension makes this a surgical emergency. Know the key distinction. Serial beta-human chorionic gonadotropin levels are only appropriate for stable patients without evidence of rupture. Methotrexate is reserved for unruptured ectopic pregnancies in hemodynamically stable patients meeting specific criteria. Expectant management is completely inappropriate when there is hemodynamic instability and free fluid suggesting active hemorrhage. The correct answer is C, emergent surgical intervention. Here is a test-taking pearl about the pelvic pain decision tree. For acute pain decision points, the first step is always to get a pregnancy test in any reproductive age woman with pelvic pain. If the pregnancy test is positive, you must rule out ectopic pregnancy. If the test is negative and the onset is acute, think ovarian torsion, a ruptured ovarian cyst, or appendicitis. For chronic pain, determine whether the pattern is cyclical or non-cyclical. Cyclical pain that worsens with menses points to endometriosis. Non-cyclical pain with fever or discharge suggests pelvic inflammatory disease. Why does this matter on the exam? The exam frequently tests this decision algorithm. Remember that ectopic pregnancy is the most dangerous diagnosis and must be excluded first. Ovarian torsion requires immediate surgery. Endometriosis is diagnosed definitively by laparoscopy. Always match the acuity of the presentation to the urgency of the next step. These decision points are extremely high yield. That wraps up our review of pelvic pain and endometriosis test-taking strategies for Step 2 clinical knowledge. Remember to review the reproductive and gynecology chapters in First Aid and your question bank. Focus on the pelvic pain differential diagnosis, endometriosis management algorithms, ectopic pregnancy evaluation, and ovarian torsion that we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.